So we need you guys to be ready for our next keynote speaker. In a few minutes, we will begin again with our exclusive speaker, Associate Professor Dr. Komal Rijal, Central Department of Microbiology, Tribhuvan University from Nepal, with the topic of a One Health approach on behavior related to use of antimicrobials and resistance in Nepal. So we will see very soon. Alright, ladies and gentlemen, welcome back again ยินดีต้อนรับเข้าสู่การสัมมนาอีกครั้งหนึ่งนะครับตอนนี้เรากำลังจะเข้าสู่ในเซสชันที่2ครับกับอีกหนึ่งหัวข้อจาก keynote speaker ของเราครับ Associate Professor Dr. Komal Rijal นะครับ Center Department of Microbiology from Nepal นะครับ Alright, ladies and gentlemen, so from now on we are going to see another interesting presentation with the topic of a One Health approach on behavior related to the use of antimicrobials and resistance in Nepal. So, ladies and gentlemen, once again, please join me in welcoming our keynote speaker, Associate Professor Dr. Kamal Rijal. Please welcome.
Thank you. Respected chairpersons, co-chairpersons, invited speakers, presenters, participants, and ladies and gentlemen. Today, I am very much thankful to the conference organizing committee, especially Faculty of Veterinary Science, Mahasarakham University, for inviting me as a keynote speaker in the conference and providing opportunity to present our research work entitled A One Health Approach on Behavior Related to Use of Antimicrobials and Resistance in Nepal. So over the last 50 years, these antibiotics, they have been widely used in humans and animals as a prophylaxis, therapeutics, and growth promoters. So widespread and inappropriate use of the antibiotics has led to the emergence of antibiotic resistance and ultimately the antibiotic resistance bacteria widespread spread in the world. And this emergence of the drug-resistant bacteria become even more prominent since the end of this century, when declining the efficacy of antibiotics were increasingly reported worldwide. So increasing antimicrobial constraints, therapeutic options, prolongs hospital stays and mortalities, lowers the quality of the human life, and it ultimately adds to the economic burden to the society. So current scenario of global impact of antimicrobial resistance on human health, at present more than 700,000 deaths are directly related to the antimicrobial resistance, and among these 700,000 deaths, 30% on the developing countries, and more than 100.2 trillion US dollar loss due to the old this AMR related issue by 2050. So it is also estimated that 58,000 newborn die from the AMR related issue. And it is also estimated among 8 people, out of 8 people, 7 people when they travel to the Southeast Asia, particularly Indian subcontinent, when they return to the European country and the United Nations, 7 of them carry the drug resistance bacteria in their gastrointestinal tract. So as we know, there are mainly 3 drug resistance bacteria are prevalent: multi-drug resistance, extensively drug resistance, and pan-drug resistance. As we know, multi-drug resistance was defined as it acquired non-susceptibility to at least one agent in 3 or more antimicrobial categories. The different antimicrobial class, if at least one antibiotic agent is resistance, that is the multi-drug resistance bacteria, and extensively drug-resistant bacteria was defined as non-susceptibility to at least one agent in all but 2 or fewer antimicrobial categories. And pan-drug resistance was defined as non-susceptibility to all agents in all antimicrobial categories present now. So pan-drug resistance is also a burden nowadays. So in 1929, Alexander Fleming was the first who discovered the penicillin. This 1925 to 1950 era was considered as the golden era in antimicrobial drug discovery. And then in 1975 up to 1975, this is the medicinal chemistry era. and in beyond the 2000, antimicrobial resistance occurs, and different bacteria, they are resistant to different class of the antibiotics. And nowadays, AMR issue is one of the public health threat, as well as it creates the global crisis. So antimicrobial resistance is a growing global health threat with multi-phased phenomenon. Infection with drug-resistant microorganism increases the morbidity, mortality, length of hospitalization of the patients, as well as treatment cost of the patients. So AMR in context of Nepal continue affect the lower middle income countries like Nepal, as they suffer from high overuse and misuse of antibiotics over the counter. So a multi-facet of the factors contribute to the development of antimicrobial resistance. A holistic One Health approach has been advocated in recent years by 2016 that aims to include the health of human, animal, and environment together. So to tackle the AMR issue, a multitude of factors contributes to the development of antimicrobial resistance. A holistic One Health approach has been advocated in recent years that aims to include the health of human, animal, and environment. So this One Health concept coordinating, communicating, and collaborating different organizations in that protect the human and animal and environment health and other partners. So the One Health concept, the objective of this One Health concept is to achieve the best health outcomes for people, animals, plants, and our environment. The holistic One Health approach is recently launched to tackle the antimicrobial resistance. So common to most the lower middle income countries, our country Nepal has also experienced huge burden of the infectious diseases such as lower respiratory tract infection, including the tuberculosis is also one of the major health problem in Nepal, and upper respiratory tract infection, enteric fever, typhoid fever, paratyphoid fever, urinary tract infections, and other bacterial infection is major problem in Nepal. And in different researchers have been reported high burden of multi-drug resistance bacteria from different clinical settings in Nepal. In present context, the multiple drug resistant rate in Nepal is different researchers reported from 50 to even 80% MDR in different clinical settings. So this burden of the MDR is due to the discrepancy between the prescription of the antibiotics by the medical practitioner and the use of antibiotics over the counter, because different geographical limitations, there are different drugs available in Nepal, and they provide the antibiotics without prescription of the doctors. So the people buy the antibiotics by the pharmacy directly without the prescription. So over the counter is also one of the issue to rise the antimicrobial resistance in context of Nepal. So much less is explored around how behavior related to use of the antimicrobials in various sectors of Nepal have contributed to rising the trend of antimicrobial resistance in Nepal. Therefore, we predicted to conducted this study. So antimicrobial surveillance in Nepal was only started in 1999 by the government laboratories, Nepal Public Health Laboratories, that is based in Kathmandu, Teku, Kathmandu, Nepal, under the government of Ministry of Health. And AMR surveillance among the animal pathogens started only in 2011 by joint efforts of Nepal Public Health Laboratory and other veterinary laboratories. And researchers have investigated different components of antimicrobial use and antimicrobial resistance in Nepal, such as the use of antibiotic in primary health care, awareness of antibiotic use and its resistance in general population, and self-medication with antibiotics among medical students. Traditionally, much of the studies related to antibiotics are exploring the use of antimicrobials in humans, and use of antimicrobials among the food animals is persistently neglected. Therefore, to address these gaps in effective surveillance, a Fleming Fund was initiated, a multidisciplinary One Health approach to tackle the AMR in Nepal by 2018. To best of our knowledge, there are no any knowledge, attitude, and practice survey on the prescription and use of antibiotics by using a comprehensive One Health approach in Nepal. Therefore, we propose this study. The main objective of our study is to explore the knowledge, practice, attitude of antibiotics prescription and usage in various sectors, utilizing a One Health approach in 8 districts of Nepal. The materials and methods study settings of our study is this study was conducted in selected 8 districts of Nepal. Nepal is a mountainous landlocked country. It has 1800 kilometer porous border with its neighbor country India in east, west and south, while it shares the northern border with country China. Currently, Nepal is divided into 7 provinces and 6 metropolitan cities, 11 sub-metropolitan cities, 276 municipalities and 460 rural municipalities. This is the recent political division of Nepal. In addition, the health system of Nepal is divided into 3 different parts: federal system, provincial system, and local health facility systems. And it is supposed that there was one primary health center in one local health facility. In addition, private hospital, private diagnostic center, nursing homes, polyclinics, and private drug dispensers serves a large population in all 7 provinces of Nepal. And this study was conducted in tertiary hospitals and primary health centers, private drug shops, around the hospitals, laboratories, private, public, and food producing farmers, and So this study was conducted in tertiary hospitals and primary health care centers, private drug shops, around the hospital, laboratories, private, public, and food producing farmers, and the 2 rural primary health centers from selected 8 districts of Nepal. You see, this is the picture of Nepal, and there are 7 provinces: province 1, 2, 3, 4, 5, 6, and 7. And we focused 8 different districts that is selected in the diagram. So from the province 1's 2 district, that is Sunsari and Morang. From the province 3, Kathmandu, Lalitpur, and Bhaktapur. Kathmandu is the capital of Nepal. And then the Chittagong districts, which is also one of the prone major area in the Tarai regions. And there's Kaski districts, that is in the province 4, and the Baake districts, that is in the province 5. So, study population, knowledge, attitudes, practice surveys were conducted on different clinician, patients, private drug seller, livestock and poultry farmers, and diagnostic laboratories of the key informants. A total of 550 participants were approached for the survey, out of which 93.8% response were received. Among 516 participants under the study, clinician and health workers were 87, private drug dispenser were 33, hospital patients were 324, laboratory head, government hospital as well as the private laboratories 23, government hospital and primary health center pharmacy 17, and livestock and poultry farmers are 32. These were interviewed. So this study is a descriptive cross-sectional study using the previously validated and reliable WHO questionnaire between May 2017 to October 2017. Participant recruitment at first a national and sub-national list of hospital, pharmacies, and the farms were obtained using a proportional sampling method. A proportional sample size for each category was calculated based on the sample size required for each category. Hospital, health facilities, pharmacy, and the farmers respondents were chosen using a simple random sampling methods. At the hospital, patients were first requested and explained about the study protocol, study objective. Patients who were willing to participate regardless of their illness were included in the study. All the patients who agreed to participate in the study were included. The procedure was repeated for other categorical respondents. A written informed consent or the thumbprint from each participant or their guardian in case of the children below 16 years was obtained. Written informed consent were obtained from all the respondents, that is the clinicians, healthcare workers, patients, hospital personnel, those who sold the drugs in the hospital pharmacy, livestock farmers. Written informed consents were obtained from all the respondents prior to the interview. These questionnaires were used following the WHO guidelines and publications. Already published WHO protocol was used for finalizing the questionnaire. 4 different questionnaires for medicine prescribers, drug dispenser, patients, and farmers were developed. Developed questionnaires were pre-tested during the orientation of the research assistants. Knowledge survey among healthcare workers consisted of 3 sections. Firstly, on the cause of emergence of antibiotic resistance. Secondly, on their existing knowledge, how on the treatment and development of the drug resistance. And lastly, on the mechanism of antibiotic resistance among the healthcare workers. And pre-testing was conducted in certain hospitals of Kathmandu Valley, which were precluded from the data for the study. So this questionnaire were development 7 days seminar conference organized in the Kathmandu, and 4 different questionnaires were developed for the medicine prescriber, drug dispenser, patients, and the farmer. And developed questionnaires were pre-tested during the orientations on certain site hospitals. And knowledge survey among the healthcare worker consisted of 3 sections. Firstly, on cause of emergence of antibiotic resistance. Secondly, on their existing knowledge, how on treatment and development of drug resistance. And lastly, on the mechanism of the resistance. Pre-testing was conducted in hospitals and few sites within a Kathmandu Valley, which were precluded from the data for this study. So research assistants were recruited for this study, 2 research assistants for each district.
ไม่เป็นไรเดี๋ยวผมทักน้องเขาไปเรื่อยๆเป็นระยะแต่พี่ไม่รีบก็ไม่เป็นไรแต่ข่อยกับยานจะรีบไงว่าหมู่บ้านเนี่ยข่อยก็ว่าโอ้หมู่บ้านลุกบ่ได้รู้สึก
ขอโทษนะคะลืมปิดไมค์ค่ะ
ในตอนกลางคืนแต่พี่
Sorry for
สั่ง
sharing.
ลุกไม่
So
ขึ้น
a
เลย
week-long workshop was organized in Kathmandu to discuss about the study, protocol, and pre-testing of the questionnaire. They were proportionately deployed for the study sites for data collection, enumeration, and data entry. This study involved data collection at different levels: individual patient level, healthcare provider, pharmacist, farmer, and healthcare facilities. Knowledge, attitude, and practice cap on antimicrobial resistance were explored using the standardized and pre-tested questionnaire adapted to each type of the respondents. Interviews were conducted with patients visiting health centers. So the survey was conducted in collaboration with National Public Health Laboratory and the hospitals. Data on antimicrobial resistance in Different settings were collected from available reports, which were tracked through the laboratory register, laboratory management information system, what we call the LMIS, and were analyzed to assess the antimicrobial resistance patterns. Assessment of recording, reporting, and laboratory management information systems on antimicrobial resistance and review of the register were also conducted in the laboratories. Information on morbidity and mortality related to antimicrobial resistance through the review of medical records data were examined. So all the questionnaire were screened and errors were processed for the data analysis. First of all, the data were entered into the EP data version 3.1 and were imported from into the SPS software version 24. Descriptive and univariate analysis was carried out by chi-square test. Statistically significant variables based on univariate analysis and research questions were selected and were analyzed using multivariate logistic regression models. Various independent variables were controlled and evaluated to calculate the adjusted odds ratio, predicting the outcome value variables that included the knowledge of antibiotics as well as the antibiotic resistance. A difference with p-value less than 0.05 was considered as the statistically significant. So results. So from our study, we have interviewed 516 respondents, out of them 87 healthcare workers, 324 patients, 32 livestock farmers and poultry farmers, 17 primary health care facilities, and the 33 drug dispenser, as well as the government dispenser, as well as the private dispenser. Out of 87 healthcare workers, 75.9%, that is 66, were male, and 24.1%, that is 21, were female. Majority of the healthcare workers were medical doctors, that is 90.2%. So among 87 healthcare workers, 79 were the medical doctors. More than 2/3 of the healthcare workers belongs to the age group 25 to 50 years, that is 63.2%. Healthcare workers were belong to the age group 25 to 50, and these of 324 patients interviewed, 72.8%, that is 246, were male. Half of the patients were from 26 to 50 years age group. Of 32 livestock farmers, 87% were male. So this is the demographic characteristics of the respondents. As I already mentioned, 516 different respondents were interviewed. Out of them, 87 were healthcare workers, and among 87 healthcare workers, 75.9% were male, 63.2% were belong to the age group adult, that is 26 to 50 years, 90.2% were medical doctor. Among them, 53.2%, 42 were MBBS, and rest other 7 MD general practitioner, 10 internal medicines. So 37 were working with the public government hospitals, and 48 were working with the private hospital of greater than 100 beds. Among 33 private drug sellers, 57.6% were the female. In the private drug seller, majority of them were female, and most of the only 57.6%, 19 were have a certified pharmacy degree, D Pharma and B Pharma. Those are required for the sold of the medicines. So among 324 hospital patients, majority, that is 72.8% were male and rest remaining were the female. 50%, that is 162, 26 to 50 years age. And majority of the patients were outpatients. 82.2% were outpatients. Among the education status of the patients, 29.9% they have only taken the secondary education, class 8 to 10. 20.1% they have completed the 10+2. Only 15.4% patients they have done the bachelor level of formal education. So among 17 hospital primary health center chief representative interviewed, 70.6% were the male. And among 32 livestock or poultry farmers, majority of them were male, that is 87.5%. So this table 2 shows the distribution of the respondents in different districts of Nepal. So as I already mentioned, we have 516 respondents regarding the antimicrobial knowledge, gap, attitude and practice survey. And these are the distribution of the healthcare workers in our selected 8 districts, distribution of the primate drug seller, distribution of the hospital and primary health centers, distribution of the hospital patients in different districts, and so on. So knowledge on the AMR, so more than 80%, healthcare workers thought the role of various underlying factors for the contribution of antimicrobial resistance. So more than 80% of the healthcare workers believe that unnecessary prescription of the antibiotics for viral infection, inappropriate empiric choice of antibiotics, inappropriate duration of antibiotic therapy, too frequent prescription of the broad spectrum antibiotics are the major factors on the emergence of antimicrobial resistance. More than 80% of the healthcare workers thought that unnecessary prescription of the antibiotics for viral infection, inappropriate empiric choice of the antibiotics, inappropriate duration of the antibiotic therapy, too frequent prescription of the broad spectrum antibiotics are the factors that cause the emergence of antibiotic resistance. Almost 40% of them were aware, that means among 87 healthcare workers, 40% of them were aware and had encountered different drug resistance bacteria during their health professional, that is in extended spectrum beta-lactamase producing Escherichia coli, penicillium resistant Streptococcus pneumoniae, multi-drug resistant Pseudomonas aeruginosa, and methicillin resistant Staphylococcus aureus. Only 40% of the healthcare workers aware about these drug resistant bacteria. Of listed mechanism of development of the drug resistance, such as efflux pump, alteration of binding site, thickening of bacterial cell wall, enzymatic process, and intrinsic resistance, majority of, that is 69 to 91% of the healthcare worker had a sound knowledge on one of the mechanism of antibacterial resistance. So hospital patients were first asked about the possibility of antibiotics in curing some bacterial and viral diseases. Out of 324 patients interviewed, 42.9% of them thought that fever can be treated with antibiotics. More than third, that is 1/3 of the patients believed that antibiotics were used for treatment of cold and the flu. Only 17% believe that antibiotics can be used for treatment of sore throat. Only 22% believe that antibiotics cure headache and skin or wound infection. So these hospital patients, they were also asked about the possibility of the antibiotics in curing some of the bacterial and the viral diseases. Out of 332 patients, 42.9% thought that fever can be treated with antibiotics. This study also assessed about their knowledge on terminologies related to resistance such as antimicrobial resistance, superbugs, drug resistance, and drug resistance bacteria. These studies also assist about the knowledge of different antimicrobial related terminology such as the antimicrobial resistance, superbugs, drug resistance, and drug resistant bacteria among the hospital patients. Of 324 patients, majority 84% of the respondents had never heard anything about the antibiotic resistance. 84% of the hospital patients, they had never heard anything about the antibiotic resistance, that is the AMR, superbug, drug resistance, and drug resistance bacteria. Only 16% of the patients, they had heard about different forms of antibiotics. Of the total 324 patients, 5.6% heard about the antimicrobial resistance. Among 324 patients, only 18 patients, they heard about the antimicrobial resistance and it related terms from media, newspaper, radio. 3.7% heard from family members and only 3.1% heard from doctor or nurses and only 4 heard from the pharmacist. Out of 324 patients interviewed, 75% of the respondents were not aware on anything related to the antibiotic resistance issue. Of 30 private drug sellers interviewed, majority 29, that is 87% of them had heard about the antibiotic resistance. However, 6 of them thought that antibiotics could treat all sorts of the diseases listed in the questionnaire. Of 33 respondents, more than half, 51.5% responded that antibiotics were used for the treatment of bacterial diseases and oral thrush. 23.3% of them responded that antibiotics can be used to treat the viral diseases and general weakness. Among livestock farmers, among 32 livestock farmers, 12.5% of them had heard about the antibiotic resistance. They had heard it mainly from the doctors or nurses. 50% of them, among 4, 2 of them known from the doctors and 2 of them known from the pharmacist. Majority of the healthcare workers, that is 76, believe that antibiotics are overused all over the country in context of Nepal, and majority of them were in support of more controlled policy required for antibiotic use. So majority of the doctors or the healthcare workers believe that antibiotics are overused all over the country, and majority 82 out of 87 of them were in support of more controlled policy for antibiotic use. Almost 2/3 of them, that is 63.3%, thought that AMR has already become significant problem in their hospitals. Out of 87 participants, majority 92% believe that prescribing broad spectrum antibiotics can aggravate the problem of resistance. Even the doctor, they believe that broad spectrum antibiotics has prescribed haphazardly, which may create the problem of the antimicrobial resistance. Most of the patients, 92.6%, believe that antibiotics should be used only when they are prescribed by medical practitioner. Out of 324 patients, 91.1% were well informed on the hand hygiene practice. Nearly 2/3 of the participants agreed that farmers should use antibiotics as minimum as possible. When they were asked on immunization, majority of the participants, that is 96.6%, were parents should ensure up-to-date of vaccinations to their children. When it came to antibiotic resistance, they were unaware about this issue, as 78.7% of the respondents out of 340 were either unaware or rejected of the problem of AMR as one of the global crises. 78.7% of the respondents, they were totally unaware, rejected the problem of AMR, antimicrobial resistance is one of the global crises. Nearly half of the respondents, 49.7%, were unsure about whether the AMR crisis has hit them individually or not. Half of the respondents, 161, were unsure about whether the AMR crisis has hit them individually or not. More than half, 58.6%, were unsure on whether correct use of antibiotics could avoid AMR crisis at individual level or not. 71.3% of the individuals had no idea about their role in combating current AMR crisis. Out of 87 healthcare workers, majority, 71.3%, reported that they prescribe antibiotic at least once a day. Out of 324 patients interviewed, majority, 79% of the respondents were purchasing antibiotics for themselves, while 61.7% of the respondents were currently taking antibiotics. 18% of them used antibiotics without prescription, self-medications. And few others, 14.8%, complained that they were not advised by doctors or healthcare workers on how to use of the antibiotics. Almost half, 46.3%, admitted that they had the habit of discontinuing the antibiotics after they felt better. On the patient response, multiple choice to buy the medicine from particular outlet, 51.9% bought medicine from near the health centers and 43.2% bought from near the resistance. So this bar diagram shows the buying of the patient decisions to buy the antibiotics from particular outlet. So 51.9% of the patients, they buy the antibiotics near to the health centers. 43.2% buy the antibiotics near to residents. 24.1% buy the antibiotic as availability of the medicine shop, and 2.5% buy the antibiotics or antimicrobial drugs where they found cheap price in the shop, and 10.5% of the patients, they buy the antibiotics as advised by the doctor or prescriber. And multivariate analysis of the people's knowledge on antibiotics showed that gender, age, persons buying drug were not significant predictor. So as the education level of the patient increased, the knowledge of the patients on antibiotics also increased. Education level of the patient was associated with the knowledge of the antibiotics. So multivariate logistic models, we find that as the education level increased, the knowledge of patients on antibiotics also increased. Education level of the patient was associated with the knowledge of the antibiotics. So this adjusted odds ratio showed that the education level of the patient was associated with the knowledge of the antibiotics. So this table shows the multivariate analysis of the predecessor on knowledge of the antibiotics, and education level increased the knowledge of the antibiotics. As related to the knowledge about the antibiotic resistance among the patients, adult patients, the age group 41 to 60 were apparently more aware of antibiotic resistance than the younger ones. Related to knowledge about the antibiotic resistance among the patients, adults group 41 to 60 years were apparently more aware of antimicrobial resistance. So knowledge on the AMR age group shows the adjusted odds ratio are given in here. And knowledge of antibiotics, person purchasing the drug were not associated with knowledge of antibiotic resistance. So knowledge of the antibiotics, person purchasing the drug were not associated with the knowledge on antimicrobial resistance. However, age of the patients, particularly the adult patient, age group 41 to 60 was found as the predecessor of the knowledge of antibiotic resistance. So this shows the multivariate analysis of the predecessor of knowledge related to the antibiotic resistance, particularly the adult patients, age group 41 to 60 years are more aware to the antimicrobial resistance. The existing condition of laboratory management information systems on AMR in hospital and healthcare facilities. A total of 17 hospitals, primary health centers were selected to gather the information on antimicrobial use, morbidity, and mortality related to AMR. Out of 17, all hospitals, primary health centers had medicines by generic name and had an essential formulary list of the medicines. So this bar diagram shows the hospital provision on antibiotic use and morbidity and mortality related to AMR from hospital primary health center record. So from the hospital, 17 hospital interviewed or 17 hospital registered monitored. Hospitals have record of mortality related to AMR. Hospitals have any record of AMR in last year. Protocols for surgical prophylaxis with antimicrobials. None of the hospitals, they are not reported the AMR related mortality, AMR hospital record of AMR in the last 2 years, and protocols required for surgical prophylaxis with antimicrobials. None of the hospitals were found. And 100% hospitals, all the 17 hospitals, they list the medicine authorized by hospital and PSC. The medicine list were displayed in the wall, and they have all the medicine listed in the generic name. 17, all the 17 hospitals. But 82.2% hospitals have medicine list in the standard treatment guidelines. 64.7% hospitals and primary health centers, they have only standard treatment guidelines for infectious diseases. In patients, hospitals 41.2%, hospitals performing a surgical intervention only 41.2%. So a total of 23 laboratories, government laboratories as well as private laboratories were assessed for performance of recording the antimicrobial resistance, performance, reporting and recording of the antimicrobial resistance. More than half, 14 of the laboratories were not purchasing ready-to-use culture media. They prepare the culture media by conventional methods. They are not purchasing the ready-to-use culture media. 78.3% of the laboratories did not have any automated blood culture system, and they relied on conventional procedures. And majority of the hospitals, laboratories, and the primary health center, that is 69.5%, did not have trained of performing the biochemical assay for confirmation of pathogenic microorganisms. 20 laboratories, among 23 laboratories, 20 laboratories, they have a conventional Dix diffusion method, modified Kirby-Bohr method for antimicrobial susceptibility testing, and only 2 laboratories adopted minimum inhibitory concentration MIC determination method for antimicrobial susceptibility testing. However, majority of the laboratories, 69.5%, were followed the Clinical Laboratory Standard Institute guidelines, CLSI guidelines for interpretation of the result, while 100% of the laboratory, they have the AST recording system of the strains by clearly indicating them as a resistant, intermediate, or sensitive. So from our study finding, we recommended some of the policy implications and recommendation for the government of Nepal. So finding from our this study bears the policy implications, particularly related to high rate of antibiotic prescription, over-the-counter use of the antibiotics, physician neglect on antimicrobial susceptibility testing, guided therapy, and lack of knowledge on regulating policy for use of antimicrobials. So these are the main scenario we observed or we found from our study, that is the rate of antibiotic, high rate of antibiotic prescription, over-the-counter use of drugs, widespread use of the antibiotics over the counter, physician neglect on antimicrobial susceptibility testing, guided therapy, and lack of knowledge on regulating policy for use of antimicrobials. Common to resource constrained setting, Nepal suffers from scarcity of laboratory infrastructure, particularly in rural regions, which can inevitably lead to the high empirical treatment. So Nepal government should aim to establish the laboratories with well-resourced with equipment and trained lab personnel. Nepal's unique geographical landscapes, population and urban-rural distribution of health service further affects the treatment-seeking behavior of the patients, including the over and misuse of the antibiotics. Aligning with these reports, healthcare workers, medical doctors also suggested for the culturally and geographically tailored guidelines for antimicrobial use in addition to the national guidelines of Nepal's. In addition, Nepal also suffers from disproportionate physicians to patient ratio and should be properly addressed. At present, the doctor's patient ratio in Nepal is mostly concentrated in the Kathmandu Valley. In the rural area, one doctor looks more than 20,000 Nepalese people. So this disproportionate ratio of physician and patient is also one of the factors that contribute the development of antimicrobial resistance. In addition, counseling on rational use of the antibiotics and its advertised should be essential elements of prescription by healthcare workers, which can be sustainable method to increase the public awareness. Patients' pressures also plays a crucial role in the prescription and use of antibiotics, which may be well reflected in primary health centers where treatment options are limited and drugs are easily available over the counter. The importance of education and mass awareness in promoting the rational use of antibiotics are also supported by several previous studies in Nepal and other countries. Antibiotic stewardship aligning with One Health approach need to be considered in future reports in Nepal. From our study finding, it is essential antibiotic stewardship aligning with One Health approach need to be considered in future reports to control or to combat the AMR related issue. Lack of protocols for surgical prophylaxis, record of AMR and mortality, morbidity in the hospital in this study implies need for the investment in protocol development and robust surveillance in all healthcare institutions. National and sub-national AMR surveillance agency, hospital organization and all stakeholders working in the sector of human health, livestock and agriculture can utilize the finding of this study to foresee future strategy against the AMR in Nepal. Collaborative efforts between the Ministry of Health, Ministry of Agriculture and Livestock Development, World Health Organization and their stakeholders are essential to implement a One Health approach. Government of Nepal, together with the leadership of WHO, can foresee One Health approach in National Action Plan on Antimicrobial Resistance. So conclusion, although the level of knowledge, attitude and practice related to prescription and use of antibiotics apparently seems improved compared to previous studies, the prescription and overuse of the antibiotics are unregulated in the studies areas that may contribute the development of AMR. Antibiotic stewardship program in Nepal can at first address these gaps through the health education, awareness, mass campaigns to mitigate the inappropriate use of the antibiotics. Importantly, reformation in policy related to use of antibiotics should consider the multiple stakeholders that shape demand, supply and compliance, including a One Health approach to ensure animal health considerations are also taken into account. So acknowledgement, we are grateful to all the patients, farmers, drug sellers, hospital personnel for their involvement in the study. We would like to express our sincere gratitude to Reverend Samuel and Dr. Sophie Quaid, WHO Country Office for Nepal for their technical support. And I would like to express my sincere gratitude to Faculty of Veterinary Science, Mahasarakham University for providing opportunity to present our research finding. And I will express, I'm very much thankful to Natupal Kumipantu, Assistant Professor of Veterinary Public Health at Faculty of Veterinary Science and Mahasarakham University for his help. So recently our work has been published in the scientific report on June 2, 2021. So if you want to know more in our research, you can go the scientific reports published on 2 June 2021. Thank you.
We still have time to ask. Anybody need to raise any question?เราเหลือเวลาอีก5 นาทีนะครับใครมีคำถามอะไรสามารถสอบถามได้เลยนะครับ If anybody have any questions you can leave the message or you can ask.
Excuse me, I have one question. Can you hear me? Okay. Good morning, Professor Komal. I have one question. Can we improve or apply the tool like KPA analysis to prevent the antimicrobial resistance problem?
Yeah, we should focus the rational use of the antibiotics. Antimicrobial susceptibility testing is established in most of the laboratories, and guided AST therapy is essential to overcome the antimicrobial resistance issue.
Good morning, Professor. Thank you very much for the very nice presentation. From the result, it sounds good. It shows good attitude from the participants about the awareness in drug resistance. However, drug resistance in bacteria is developed. Why, in your opinion, may I ask about what is the most analytic useful to control this problem?
Can you again speak the questions? I do not hear properly.
Yes, maybe I too much. I mean, what is the most sensitive useful to control drug resistance problem?
Yeah, in Nepal, basically the multi-drug resistance tuberculosis, MDR-TB, and is typhoid salmonella infections, and basically the nowadays MDR E. coli, particularly isolated from the unit tract infections, are the most issue. Beta-lactamase productions are the most issue for antimicrobial resistance.
We have some question in the chat box for later. Somebody, her name is Tanyakon, asked about how can we protect ourselves from antibiotic resistance, Professor? Did you hear me? May I ask again, how can we protect ourselves from antibiotic resistance?
Yeah, we use the rational use of the antibiotics is one of the major, that means preventive for the production or the prevention of the antimicrobial resistance.
Okay, thank you, Professor. We have addition question from Ms. Benjawan. She asked, what is the major problem that caused the antimicrobial drug resistance in your country?
Yeah, well, that is the prescription. Without prescription, the people buy the antibiotic in the drug shop, as I already saw in the graph. People brought the antibiotic over the counter. 55% where they buy the drug without prescription, and they buy over the counter. They buy near the resistance. So these are the major problems to create the antimicrobial resistance. And most of the farmer and livestock person, they use the huge amount of the antibiotics in their feed and in their poultry. So that also creates the antimicrobial problem in our country. So we must regulate we have no exact policy how the antimicrobials are used. So it is essential to develop a One Health approach to combat the current AMR issue in Nepal. So our study focused on One Health approach, how we use this One Health approach to combat the AMR crisis in context of Nepal.
Thank you, Professor.
Thank you for your questions, and thank you again. I am very much thankful to Faculty of Veterinary Science, Mahasarakham University, for providing this opportunity to present our research findings. Thank you.
Thank you very much. Can you guys give a big hand of applause for our Associate Professor Dr. Komal Rijal? Thank you very much. ครับซึ่ง